All right, good morning. It is February 11th, and this is Senate Health and Welfare. This week, we're looking at a number of bills that we hope we can move along as we get toward crossover. And we're beginning a discussion on a potential committee bill. And I will talk about the genesis of the bill before we begin. I'll do that right now because Jen Carvey is here to go through what we put together. The genesis of the bill is just listening to everyone about where we are with a need for healthcare reform and changes in payment, hospital costs that are soaring, and our commercial insurance companies becoming insolvent. There's just a number of different issues are compelling us to do something to make change, some quickly and some more gradually. In addition to that, we heard from the Oliver Wyman report about the need for health medical records integration and how to make medical records accessible to clinicians as well as to patients and others. So that's part of the bill. And then we've also heard from the Green Mountain Care Board and Agency Human Services a need for a statewide healthcare delivery plan so that we can have a better sense of what we need and when we need it. And I think that at the end of the framework, you'll see payment issues related to regulation, increasing the board's ability to regulate a particular hospital payment and hospital costs. And then Larry, Senator Hart, you should probably mute yourself.
I probably should.
Okay, we're good.
See, and I'm coughing up so much, so.
Well, I'm sorry that you're not well.
Actually, I'm feeling better today than I did yesterday, and tomorrow I'll probably be over there, but I'm wearing a mask just for the heck of it.
All right,
because I don't want to get Senator Cummings or any of the rest of you guys sick. I think I was sitting next to Megan Gray, and when she was having her coughing spree, and I think I gathered some of her germs. So.
All right. Well, we're good. Just hold them right there. Don't send them anywhere else.
So okay. I'm actually fighting it pretty well, and between my regimen of NyQuil and DayQuil, I'm feeling a lot better. So.
All right. Thank you.
Okay.
Thank you. Terrific. Okay. So, in other words, there are different sections of the proposal. There's a healthcare delivery plan. There's it has a couple of sections, and there's a section on electronic medical records or data aggregation of medical records, hospital budgets and payment reform. It takes up a good deal of it, and then a section on resources needed. And I know I'm going to hear from people who say we can't do this without more resources. So that's why we put this on the table, and then I look for improvement. I know that people want to take things out and put things in. This isn't a final product by any means, but it has really come from dialogue with many of you and your help in putting this together. And there, of course, are different perspectives represented. So there are different perspectives in the proposal. I will take full responsibility for anything you don't like. And I'll help share responsibility for what you do like. And I know that we've asked Elliot Fisher and Chris Kohler and others to speak with us last week to kind of set the table for what we need to do. And we'll have other experts coming in this week and next week. And if you have suggestions for what would help us, I would greatly appreciate hearing from you about that. I haven't heard from too many folks about experts except from Elliot Fisher. Okay, so that's it. So we should be a little joyful because we're finally getting this thing out on the table. Glad of that. So Jen, why don't you, I think maybe put it up on the screen and then, we'll go through what's here. Could be earth shattering, but it probably is. I never know what.
All right, good morning, Jennifer Carvey from the Office of Legislative Counsel. So this is a draft outline. And so this is just an outline form. It is not drafted as legislative language, but of a potential committee bill on healthcare reform. It has several parts. The first part is what we've called, at least for now, a statewide healthcare delivery plan. And it directs the Green Mountain Care Board and the Agency of Human Services in collaboration with interested stakeholders to develop an integrated statewide healthcare delivery plan that builds on data from the Health Resource Allocation Plan, from the Act 167 Transformation Planning, and related data to ensure access to high-quality, cost-effective acute care, chronic care, primary care, and hospital-based, independent, and community-based services across Vermont. It says the plan will include ensuring that mental health services, substance use disorder services, emergency medical services, non-emergency medical services, and non-medical services and supports are available in each region of the state. It will build on data from the Green Mountain Care Board, the Department of Health, healthcare providers, and other relevant data sources. Plan will identify gaps in care as well as circumstances in which service closures or consolidations may result in improvements in quality, access, and affordability when considering the current and future needs of Vermonters. We'll identify opportunities to reduce administrative burdens such as contracting complexity, payment term complexity, and quality reporting requirements. It will identify federal, state, and other barriers to achieving the plan's goals, and to the extent feasible, how those barriers can be alleviated. It would require Vermont hospitals to submit their own hospital strategic plans that are aligned with the statewide healthcare delivery plan. And the bill could either specify the minimum requirements or direct the Green Mountain Care Board to establish those minimum requirements. It would direct the Green Mountain Care Board to review and approve the hospital strategic plans for alignment with the statewide healthcare delivery plan. And it would direct the Green Mountain Care Board hospital budget review process to include consideration of a hospital's alignment with its strategic plan. And then this section would require the Agency of Human Services to monitor other state agencies for alignment with the statewide healthcare delivery plan. So that's part one.
Do you want to do a stop? In the
Sure.
middle? Does anybody have a question there at this point? It's pretty broad, but one thing would like to emphasize is that we heard last week a need to revisit and put emphasis on primary care. So this will ensure that that's in the planning process.
Yes. All right, part two is a health system evaluation to support improvement and development of the statewide healthcare delivery plan. This directs the Green Mountain Care Board and the Agency of Human Services to jointly establish an advisory committee to oversee an evaluation of the current health system performance and the development of the statewide healthcare delivery plan. It directs the Green Mountain Care Board to solicit input from the advisory committee to design an evaluation approach that the board can implement that will continuously monitor current performance in all sectors of healthcare delivery to identify opportunities to improve access to care, clinical quality, and population health while reducing the total cost of care to the extent possible. And it requires the Green Mountain Care Board and Agency of Human Services to ensure that the evaluation, planning process, and implementation of related programs are timely, transparent, and open to feedback from interested stakeholders, including the public.
So I would just say that this recommendation comes to us from Elliot Fisher and some of his folks. And I put it in here, added in because they feel that it's critically important to have some kind of advisory support for the work that's being done ongoing. I mean, it could be we could say do it, or we could say evaluate how it should be done. So, yeah, it's in here.
Part 3 is integration of clinical and cost data for clinical improvement, regulation, health system evaluation, and policy development. This would direct Vermont information technology leaders vital to lead all payers and healthcare providers in the technical development of a system of clinical and claims data in order to improve patient, provider, and payer access to relevant information and reduce administrative burden. This process would be required to follow Vital's established standards, utilize and follow the Health Information Exchange Steering Committee's plan to the extent practicable, determine the steps necessary for interoperability between providers, establish a timeline for setup and access, identify the resources needed to complete data linkages for clinical and research usage, and develop a system that ensures rapid access for patients, providers, and payers. It would identify for future planning interoperability for emergency medical services providers and including a linkage between the Department of Health and the WIC program. Full name these days is the USDA Special Supplemental Nutrition Program for Women, Infants, and Children. And it would direct Vital to share data with state agencies and healthcare providers as needed to support the goals of the statewide healthcare delivery plan.
So, already we do have an expert in the state who has worked with data aggregation, clinical data aggregation. And some of you may remember Craig Jones from the Blueprint. He also has comments to make about the Blueprint going forward. But he will be coming in to talk with us. He's agreed to come in and talk with us about this, as well as others. I know VPQHC felt that they should have an opportunity to come in and tell us what they do. So they'll be coming in. That's the idea here, is to follow up on integrating our clinical data and have an integration of clinical and cost data so that we know, one, so that clinicians have access, and then two, that patients will have access going forward. We'll see how that fits.
All right, part 4 has several kind of subparts. So this is on hospital budgets and payment reform. The first category of this is reference-based pricing. This would require reference-based pricing for hospital prices in the commercial market at a percentage of Medicare prices to be determined by the Green Mountain Care Board in order to move hospitals from their current price site-neutral approach, while allowing for price differentiations based on demographics, population health, and a hospital service region, and for a particular hospital's role in the healthcare system. It would require the Green Mountain Care Board, in collaboration with the Blueprint for Health and other state agencies where appropriate, to implement reference-based pricing to increase or decrease rates for non-hospital services as appropriate to align with the statewide healthcare delivery plan. So they might be set higher or lower than current in order to incentivize or desincentivize certain types or settings of care. And it directs the Green Mountain Care Board to solicit input from payers on ways to approach reference-based pricing in an effort to achieve all payer alignment on reference-based pricing design and implementation. You stop after each of these, or just keep going?
Yeah, well, we're going to be hearing from a couple of folks on payment reform, records-based pricing, and probably in addition, we'll be asking someone from Green Mountain Care Board to come in and talk about what's happened in Vermont. We've got someone coming in next week. I don't know whether it's going to be Wednesday or Friday, but next week on just budgeting and payment reform, who from TUS. And so we'll get some basic information. I know there's a lot for many of us to have on that. And then you have a comment you'd like to make? No, okay. So we have many people in our state who understand reference-based pricing, and there are many of us around the table who know it a little bit better than others. So what we need to do is to get payment reform 101. We're going to do that, and then we'll hear from folks in the room and folks from Green Mountain Care Board to understand how we might move ahead. We don't want to reinvent any wheels with this one. We know we've got ways to go to understand.
We have total cost of care. We direct the Green Mountain Care Board to establish total cost of care statewide spending targets to recommend growth rates that would bring hospital and total healthcare spending to at or below national growth rates of GDP, and adjust them as needed to bring Vermont total healthcare spending back in line with or better than the U.S. average. But also direct the Green Mountain Care Board to establish targets for primary care and preventative care spend, including mental health spending, that are aligned with the statewide healthcare delivery plan and the total cost of care statewide spending target.
So in that, obviously there are some short-term and long-term things that are going on. And so we're going to see that some of these things are longer term. Once you have a plan, then you can start to do some of this. It takes time. Yes, ma'am.
I don't know, I'm getting buried in words and plans. We have some plans, right?
Yeah.
It might be helpful to see what those plans say and evaluate what they have or haven't achieved, which would give us a base going forward, because I'm seeing this as a crisis. I mean, it's a financial crisis. And I'm not sure we've got time.
Well, this is what I say. What we're looking at here is we're looking at some of the longer term issues, so that we'll keep going. And we have, what we would like to do is to identify the emergency steps that we can take. So there will be, hopefully there'll be something as we move along that are more immediate that we can do, or the board can do.
Do we have a healthcare delivery plan?
No, we have a HRAP, and we have a health resource allocation plan. But we don't have a full plan as described here, and the board has really been very interested in having something, as well as others.
As we were told this morning, we might want to base our school districts on the hospital service area map.
There we go. Is that part of the HRAP? I don't know. We'll find out.
I would like to see that.
Yeah. Dig in and see what all the plans are. I think everybody has a plan. Every hospital, every Green Mountain Care Board, everybody has a different plan. So this is an opportunity to integrate those. May not be the emergency step, that the first step, but certainly something.
All right, then we get into global hospital budgets. This would direct the Green Mountain Care Board to establish budgets for Vermont hospitals that are consistent with their total cost of care targets. And to the extent that federal requirements affect Medicare or Medicaid services, it would require the board to collaborate with the Agency of Human Services to ensure compliance. It directs the Green Mountain Care Board to establish standards for global hospital budgets and start implementation by 2027, beginning with the 5 largest Vermont hospitals. It would build on reference-based pricing implemented for commercial insurers, allow the Green Mountain Care Board to hire a contractor to support the development and implementation of these budgets, and it would require all Vermont hospitals to have a global hospital budget by 2029. It also requires the Green Mountain Care Board to establish outcome measurements to ensure that hospital costs are appropriate and the quality and access are maintained or improved. Nothing there, you want me to go into regulatory duties. Green Mountain Care Board regulatory duties. This directs the Green Mountain Care Board to propose revised timelines for its annual health insurance rate reviews and hospital budget reviews to improve coordination. It has certain things that would start in 2026. The Green Mountain Care Board must ensure that hospitals implement their budget orders in a manner that is consistent with their approved hospital strategic plan. We have the board, in collaboration with the Department of Financial Regulation, require any decrease in hospital services result in decreased insurance premiums. It would require that any proposed discontinuance or closure of a hospital service require application to the Green Mountain Care Board, which would review through a reverse certificate of need process to be developed by legislation and board, and will include evaluating the proposal for consistency with Act 167 transformation efforts and the statewide healthcare delivery plan. And starting in 2026, the Green Mountain Care Board will require hospitals to include in their budget filings and for audit purposes the ratios of executive and other administrative salaries to clinical and other staff salaries. It would also require hospitals to transition to a uniform system of accounts so that the Green Mountain Care Board can directly compare hospital expenses between hospitals. And it would direct the Green Mountain Care Board to contract with a single independent auditor to be paid for by the hospitals to conduct an audit of all Vermont hospitals in order to increase transparency about hospital costs and expenditures, ensure that hospitals are using the same criteria to identify their administrative, clinical, and other costs, and quantify spending that does not relate to patient care. Would have contracts last for 3 years and be required to be rebid every 3 years. Finally, we have payment for clinical services. This would direct the Green Mountain Care Board to collaborate with interested stakeholders to develop payment models aligned with the statewide healthcare delivery plan and the Act 48 principles of healthcare reform. And it would require hospitals to submit improvement plans for Green Mountain Care Board approval. The board would review for alignment with the statewide healthcare delivery plan and consult with the clinical advisory board.
So on the audit piece, we haven't talked about audit. We had asked a question last week about audit in here, and we will have someone coming to speak with us from Harvard about audits as well as the state auditor. I did talk with Nancy Kane yesterday, yesterday to come in and talk with us, and she will do that. I thought she was coming in tomorrow. I'm confirming with Kiki now, which will get up on the agenda. She came to us by way of Elliot Fisher, so we're glad to have that. And we did hear from the medical center that they would welcome an audit, but there are audits and there are audits, so we're going to sort that out. Go ahead.
All right, finally, we have part 5, resources, and this creates 5 new positions at the board in each of the fiscal years 2026, 2027, and 2028. So it would add a total of 15 new positions over 3 years. And it would appropriate some to be determined amount of additional funds to the Green Mountain Care Board in fiscal year 2026 for those 5 positions, contracts, and other needs to be identified.
So I also understand that, this is kind of what we've heard from the board in terms of their needs. I know that there are positions the governor has put in his budget. So that'll be an appropriations discussion going forward. But they absolutely, if they're going to accomplish anything in the short term or the long term, they're going to need some support. And some of that support is not currently at the board. So there may be a need for contracted services that the board can access as they gain capacity to do some of the work. In terms of payments and budgeting, the way I'm looking at this last page is we have yearly budgets, and some of the provisions in here can direct the board to begin to look at, for example, administrative versus staff, to look at the effect on premiums. It can do that immediately. The board has capacity, I think. We'll hear from them. And then beginning to look at, global budgeting and however that sorts out. I think we have some states that we need to look at, whether it's Pennsylvania, Montana, Maryland. We can, look at some of the states that this go. So there is a lot here. So that's it. And what I'm gonna suggest, is. Okay. That would be good. It's like a little, I thought activity going on today, both outside and inside. Like, I think I'd like to go through it again.
Okay.
And, I guess what I'm gonna suggest is we have lots of time this morning, to look at this before our guests come in. We have about an hour. And I know that that all of you, sitting around the room are looking at it thinking, oh my goodness, we can't do all this, or it was too much, or this is not enough. I don't know what the response is, but the goal here is, to begin to look at some of the things that we've heard about in terms of costs increasing over the top, and how can we lower those costs and become more in line, in particular for some of our larger hospitals, how can we become more in line with what's happening nationally without doing it too fast? And that is a problem. And then at the same time, how can we save our commercial insurance market? Problem.
I saw a statistic the other day that our bronze plan, was twice as much as Maine, which has similar demographics. Can we look at that?
Our which?
Bronze,
Our bronze plan.
yeah, twice as much as Maine, so what do we do? And we're like twice as much or more of the national average, so I'm concerned that while we're planning, people are gonna lose their health insurance.
Well, if
Because
you look,
it becomes unaffordable.
yeah, exactly. So I think our goal in here is to look at what we can do relative to hospital costs. And as we look at regulating hospital costs, what effect, if any, can they have on insurance premiums to do exactly what you're saying, to lower those costs? It's not it's not linear. That's one of the problems. But, go through Green Care Board to DFR. There's a lot of payment.
We have done things to the exchange that other similar states have. And I know as we've added services, yes, everybody should have them, but if it's reached a point where people can't afford them, then are there things we could remove that might make it more affordable? Good question. And I'd just like to see what they cover and
Versus
we
what
cover
Maine covers.
and be able to do the trade-off. I don't think anyone wants to reduce coverage, but if you can't afford insurance, you get no coverage.
So who can help us understand that? Where did you read that particular piece of data?
It may have been in Digger. Where I read, but it's not the first time I've heard it. Our cost, across the board, our costs are education, hospital.
Well, changing a plan, the bronze plan, or removing services is probably not something that can happen automatically, but
No.
certainly could be directed to.
It's just, we should know,
Yeah,
then we can make a decision, but we should know if it's something we've done or is it just the cost of hospitals?
well, we're hearing the cost of hospitals is driving costs overall, including commercial rates.
Yes,
Which is really, that's been the biggest dialogue or monologue or whatever log I've heard. I think we all have heard, and we've heard that our academic medical center is by far the highest in the country. And, yeah,
Starting to wonder if we can afford it.
yeah. So that's really what we're looking at, targeting.
I was just going to underscore what Senator Cummings said. We did last week when we had our joint hearing. There was talk in the room about having an emergency plan
Yeah,
either in place or in the works that might sort of mimic a little bit of, some of the policy that took place during the COVID period. And I don't know what that would look like. And I know that's not what this is, but
well, it is. If you look at the Green Mountain Care Board regulatory duties as 2026 and looking at budget, it gives them more authority to make changes within the budget process. So it's at the end of the list, but it's probably, for me, it leads us in the direction of what can we do immediately? What can the board do immediately that will reduce costs and lead toward helping commercial insurers? I mean, yeah, and it's not called an emergency plan because I think once it starts, it should be ongoing. I don't think it should be just because we're in COVID. I think it should be something that goes on and gives the board that authority going forward. But my thought there, and I think the thinking there from others is to see what we can do quickly. So I think we should start at the end and go backwards. But we deliberately put the plan first because it's softer. But I see the healthcare advocate is here, the hospital's here, the commercial insurers are here, our academic medical center is here. And if you have questions or just you can ask, I would like you to ask. Why don't we go through again? And we'll engage in questions and conversation. I'm happy to hear your comments off the top. Oh, I hate this. No, I love it. Okay, whatever it is, it's important for us to understand. And then we'll be bringing you in for testimony. It'll be great. Okay, so we'll start at the top. Okay. Page one.
Page one, part one is the statewide healthcare delivery plan. Directs the Green Mountain Care Board, the language would direct the Green Mountain Care Board and Agency of Human Services in collaboration with interested stakeholders to develop an integrated statewide healthcare delivery plan that builds on data from the Health Resource Allocation Plan, the HRAP, Act 167 Transformation Planning, and related data to ensure access to high quality, cost effective acute care, chronic care, primary care, and hospital-based, independent, and community-based services across Vermont. The plan
So just stopping right there. You all know Act 167 is ongoing and there's a hospital transformation process. So this links in greatly with that work.
Some of us that weren't here don't know. I guess that's
Yes,
part of it.
okay.
The plan will include ensuring that mental health services, substance use disorder services, emergency medical services, non-emergency medical services, and non-medical services and supports are available in each region of the state.
So that links in with things like hub and spoke, counseling services, and then again, linking our medical and social services that is a part of, again, as part of 167, but I think it's something that everyone is interested in.
The plan will build on data from the Green Mountain Care Board, the Department of Health, Vermont healthcare providers, and other relevant data sources. It will identify gaps in access to care, as well as circumstances in which service closures or consolidations may result in improvements in quality, access, and affordability when considering future needs of Vermonters. It will identify opportunities to reduce administrative burdens, such as contracting complexity, payment term complexity, and quality reporting requirements. And it will identify federal, state, and other barriers to achieving the plan's goals, and to the extent feasible, how those barriers can be alleviated.
So it could be transportation. And I know AHS is working very hard on issues around transportation and transportation planning.
It would also require Vermont hospitals to submit hospital strategic plans that are aligned with the statewide healthcare delivery plan. And it could either specify the minimum plan requirements or direct the Green Mountain Care Board to establish them. It would direct the Green Mountain Care Board to review and approve the hospital strategic plans for alignment with the statewide healthcare delivery plan, and would direct that the board's hospital budget review process include consideration of a hospital's alignment with its strategic plan.
So obviously, this isn't something that happens next year. This is a process. I mean, building the plan is a process, and Senator Cummings says it's not the emergency piece. It's the piece that goes forward as 167 hospital transformation and other, whether it's transportation or other housing or whatever this plan goes on. But it's certainly, it's beginning to be more thoughtful about how each hospital region connects with every other part of the state, and how community services are or are not filled, how to get them.
And it would have the Agency of Human Services monitor other state agencies for alignment with the statewide healthcare delivery plan. Yes. Part 2.
So let me just say this. So as you folks are thinking about us, as well as everyone else in the room and out in Zoom, as you're looking at this, how can we improve what we have here and make it doable within the next 18 months or 24 months to plan?
Part 2 is the health system evaluation to support the improvement and the development of the statewide healthcare delivery plan. This would direct the Green Mountain Care Board and the Agency of Human Services to jointly establish an advisory committee to oversee evaluation of current health system performance and the development of the statewide healthcare delivery plan. It would direct the board to solicit input from this advisory committee to design an evaluation approach for the board to implement that will continuously monitor current performance in all sectors of healthcare delivery to identify opportunities to improve access to care, clinical quality, and population health while reducing, to the extent possible, the total cost of care. It would also require the board and the Agency of Human Services to ensure that the evaluation, planning process, and implementation of related programs are timely, transparent, and open to feedback from interested stakeholders, including the public.
So as I look at this and think about this, this is a recommendation that's come to us from, as I said before, from Elliot Fisher, and I'm not sure it fits with the work that has to be done on the plan. I think it's more like, do we need, and how would we have an advisory committee? It's not setting it up right in front, because it presupposes that there's a plan in place. So I asked Jen to include that recommendation because they felt it was so important, but they may be 4 steps ahead of us in having a plan in place. If you can't have an advisory committee to have a plan, we don't know what it would look like. So
Right. I think it does talk about the advisory committee overseeing development of the plan.
yeah,
I think their proposal is to have an advisory committee
we'll have
involved.
to think about that. Yeah,
I don't know. More clarity.
seems like we're more than we need. I don't. Maybe the board and AHS will come back and say we need it. I don't know. We'll see. We'll hear from Tesco. We'll hear what people ask. I'm not wedded to anything. I just want to know what we can do. Yeah. Okay.
All right. Part 3 is integration of clinical and cost data for clinical improvement, regulation, health system evaluation, and policy development. This part directs the Vermont information technology leaders, vital to lead all payers and healthcare providers in the technical development of a system of clinical and claims data in order to improve patient, provider, and payer access to relevant information and reduce administrative burden. This
I just want to let folks know that two of our committee members are on Zoom, so we're all here. And Senator Gulick has an obligation outside for a few minutes to be done.
All right, this Vital-led process will follow Vital's established standards, utilize and follow the Health Information Exchange Steering Committee plan to the extent practicable, determine steps necessary for interoperability between providers, establish a timeline for setup and access, identify resources needed to complete data linkages for clinical and research usage, and develop a system that ensures rapid access for patients, providers, and payers. Also, it identifies for future planning interoperability for EMS providers and including a linkage between the Department of Health and the WIC program. It also directs Vital to share data with state agencies and healthcare providers as needed to support the goals of the statewide healthcare delivery plan.
So again, there are probably steps in here. A lot of this is very technical, so it'd be more of a technical working group to put the data together. And then there may be some things that can happen faster than others, but fast by a year or so. And then some that require a lot of time, including interoperability, emergency services, and linking in some of the more discrete folks groups. But it's something that came out of Oliver Wyman report indicating that it would be beneficial to have an integrated electronic medical records and access for everyone to include in that. I'm sure payers, providers, and patients.
Okay, part 4 is hospitals and payment reform. In the first category, there's reference-based pricing. Require reference-based pricing for hospital prices in the commercial market at a percentage of Medicare prices to be determined by the board in order to move hospitals from their current pricing structure to a site-neutral approach that also allows for price differentiations based on demographics, population health in a hospital service region, and or a particular hospital's role in the healthcare system. It would require the board, in collaboration with the Department of Health and other state agencies as appropriate, to implement reference-based pricing to increase or decrease rates for non-hospital services as appropriate to align with the statewide healthcare delivery plan. And it directs the Remand Care Board to solicit input from payers on ways to approach reference-based pricing in an effort to achieve all payer alignment on the reference-based pricing design and implementation.
Okay, we hear that reference-based pricing may save us. We also heard from our consultants last week that having it be broader rather than specific to one cohort of one group is better to have it broader than narrower.
Hi, Devin Green, Vermont Association of Hospitals and Health Systems. I just have a clarification question around the non-hospital services. Is that outpatient services of an affiliated provider, a provider that's affiliated with a hospital, or is that all non-hospital services?
Yes, it could be both, but it's not. So it's not something that happens quickly if you're going outside to have some uniform pricing.
Are you talking about
I-
reference-based pricing for independent primary care providers?
Right, I think at this
That's
point,
fine.
anything is on the table, and
Yeah, it's all out there.
Yeah.
when it gets turned into legislative language, it would have more specificity and it's based on decisions.
And one of the things that we might hear about going forward when we get to payment reform is having payment types based on clinical diagnosis. So it could be based on diabetes, cardiovascular needs. And so beyond our pay grade, way above it. So, and not something that we can put into a bill automatically. But good question. And the answer is yes, but then we need responses and help going forward.
Okay, and then we have total cost of care. This would direct the Vermont Care Board to establish total cost of care statewide spending targets, recommend growth rates that would bring hospital and total healthcare spending to at or below the national growth rates of GDP, and adjust as needed to bring Vermont's total healthcare spending back in line with or better than the US average. Would also direct the board to establish targets for primary care and preventative care spend, including mental health spending, that are aligned with the statewide healthcare delivery plan and the total cost of care statewide spending target.
And I'm sure that there'll be a lot to be said about that. HS, go ahead.
Oh, we heard the head of our largest hospital say they were providing excellent care. I have no doubt that they are. And he thinks that we got off fee for service and went to global payments. However, when asked, said yes, his global payment would be what he's getting now with an inflator. We're talking about hospitals, and not all hospitals are this level. For some hospitals that are significantly in the red, reference-based pricing could put them under.
Exactly.
So I want to balance that, but I'm also not seeing a stick. I mean, we've been telling people to get your prices down for years. We can't. They were told to get them down, and they cut very vulnerable services. Without any discussion, and I've told the staff or the community or any response. And I'm just wondering, since I'm not sure everybody is a willing player in this game, I haven't heard from all hospitals. What do we?
We'll have to hear from all hospitals.
And what are we doing different than other states? Are the hospitals in Maine in the red? Or is Maine just putting more money into the hospitals? I mean,
So this is, yeah,
you're doing different.
Yeah, you raised exactly what we need to hear more about, and that is what are those other states doing that Chris Kohler was talking about. So we'll try to dive into that a little bit more as well.
Yes.
And what are the carrots and sticks?
Yeah.
So carrots are, hospitals might need some help initially to make things happen, so need some support. And some hospitals more than others. We have 5 larger hospitals. Maybe we start with those on some of this and then move to the smaller ones. I think that's in here, so. Yeah,
It's coming up.
and we'll move on, keep going, because it's there, but you're asking all really good questions.
All right, then we have global hospital budgets. Directs the Vermont Care Board to establish budgets for Vermont hospitals that are consistent with the total cost of care targets established by the board. And to the extent that federal requirements affect Medicare or Medicaid, the board would collaborate with the Agency of Human Services to ensure compliance. It also directs the board to establish standards for global hospital budgets and start implementation by 2027, beginning with the 5 largest Vermont hospitals. It would build on the reference-based pricing implemented for commercial insurers, allow the board to hire a contractor to support the development and implementation of the global hospital budgets, and require all Vermont hospitals to have a global hospital budget by 2029. Would also direct the board to establish outcome measures to ensure that hospital costs are appropriate and that quality and access are maintained or improved.
So this is where a contractor might help the board as it fits up itself to do some of the work going forward.
Sarah Teachout from Blue Cross. I just have a question. Is the intent to move forward with global hospital budgets with or without a head?
With or without a head. This had
Okay.
nothing to do with a head.
Okay, so it's,
Yeah, and so it'll begin to establish some parameters for statewide, for global hospital budgeting, with or without.
okay,
Good question.
thank you.
Yeah. We can't get it too. Yes,
Then we have the Green Mountain Care Board regulatory duties. Would direct the board to propose revised timelines for its annual health insurance rate reviews and hospital budget reviews to improve their coordination. Certain things in starting in 2026, the board must ensure that hospitals implement their budget orders in a manner that is consistent with their approved hospital strategic plan. That the board would have the board in collaboration with the Department of Financial Regulation require that any decrease in hospital services result in decreased insurance premiums. Require that any proposed discontinuance or closure of a hospital service require application to the board for review through a reverse certificate of need process that the board and legislation would develop, and that will include evaluating the proposal for consistency with the Act 167 transformation efforts and the statewide healthcare delivery plan. And the board would start requiring hospitals to include in their budget filings and for audit purposes the ratios of executive and other administrative salaries to clinical and other staff salaries.
so just stopping there for a second, I see a lot of these things, a lot of this section that could start sooner than later as budgets are reviewed. The question about reverse CON process, other states are doing this. We had found out, and I think Nolan, you helped bring that to us. And I think that the House I don't know whether they're looking at it in their CON bill or not, but it's something that we might have in place so that we don't lose services for the sake of lowering costs. So eventually there'll be a plan in place so we know when and how to change services.
Yeah, do we want to start now saying that every hospital has to deliver all the services they're delivering now?
Yeah.
Because maybe there's a better way
To do it.
to do it. And so if we put in the plan that hospitals can't impact the services, we're kind of tying their hands.
Yeah, we don't want to tie hands, but we do need to understand justification for what's happening. And I know the hospitals right now are very much engaged with the transformation process through 167.
Right, and this does
Yeah.
talk about having the reverse CON process include evaluating the proposal for consistency with the Act 167 transformation efforts.
Right.
And the statewide healthcare delivery plan to see if
If we don't have a statewide health plan, I can't go. If you don't have a statewide health plan, you can't be consistent with it. So you can begin
Right, you would
with
start
what
with the Act.
the hospitals are currently doing. We're not trying to bind the hospitals to doing something that we say is important, but rather that's worked out with the hospitals and their local service area, with AHS, with Green Mountain Care Board, with what the needs are, how to help them.
All right, it would require hospitals to transition to a uniform system of accounts so that the board can directly compare hospital expenses. And it would direct the board to contract with a single independent auditor to be paid for by the hospitals to conduct an audit of all Vermont hospitals in order to increase transparency about hospital costs and expenditures, ensure the hospitals are using the same criteria to identify administrative, clinical, and other costs, and to quantify spending that does not relate to patient care. It would be a 3-year contract to be rebid every 3 years.
So thinking about that, that's a lot of work right there and a lot of money, but it may be that you begin with the larger hospitals and then move as needed. Yes, ma'am.
Devin Green, Vermont Association of Hospitals and Health Systems. For this audit piece, this is the So you're saying hospitals, you can no longer choose your own auditor. You have to do this auditor, or is this an audit of the hospital's audits?
It's a separate audit. It's a separate independent audit. And we'll hear,
Audit?
yeah, we will hear from, the person I mentioned earlier, from Harvard, who can share with us how and why this might be important. And we can decide whether to move forward with it or not.
And finally, in this part, we have payments for clinical directs the Green Mountain Care Board to collaborate with interested stakeholders to develop payment models aligned with the statewide healthcare delivery plan and the Act 48 principles of healthcare reform. And it would require hospitals to submit improvement plans to the board for approval. The board would review for alignment with the statewide healthcare delivery plan and consult with the advisory board.
So this one really gets into the weeds, but that's not our weeds to be gotten into, but it will take some time to work with this, but it is an opportunity, I think, to look at where fee for service falls, where block grants fall, where do value-based payments fall within the clinical range of services. Not something we can do in here, and even I don't know whether the board is ready to do this or not, but there's certainly opportunities here. And I'd say not this year, maybe not even next year, but moving forward to begin to look at this.
Finally, we have part 5, resources. This creates a total of 15 new positions at the Green Mountain Care Board, 5 new positions in fiscal year 26, 5 in fiscal year 27, and 5 in fiscal year 28. And it would appropriate an as yet undetermined amount of funds to the board in fiscal year 2026 for those 5 positions, contracts, other needs that are identified as we work through this.
So the board obviously will need new positions, need help, maybe a contractor initially. And then I think, what we will probably hear from hospitals is they are going to need help. Everybody's going to need help. So we'll see what happens, what goes forward. So that, any other questions? Questions? There's a lot here. It's a framework, as I said before. But I think in particular, the Green Mountain Care Board regulatory duties section. It's in section 5, page 3. Those regulatory duties are things that, for me, begin to fall into an emergency response plan. Things that might happen during the budget process that could change the course. We need to do something fast. If you can think of something that we can do fast without causing remember the balloon that Elliot Fisher had? If you do one thing here, it pokes out there. So if you do a small cohort of reference-based pricing, it might fall out here with a balanced billing change. So we can't just do one thing and expect we're going to cure everything. Might save money there, but it might hurt somebody else. So the goal for us here is to do what we can in an emergency situation that isn't going to result in some problem somewhere else. So if you can think of something, I mean, all of us, if we can think of something additional that will help us lower the costs, add financial sustainability for our hospitals and our commercial insurers, in particular Blue Cross and Blue Shield. If you can think of that, we'll try and do it. So these are just a few things that are here that get us started thinking. Now that's it. And I'm looking at because I know he's going to help me. So, he always does. Mike, go ahead.
Mike Fisher, healthcare advocate. So very high level. Sort of initial thoughts. sort of recognizing that, I'd love a chance to come back in and I may change my mind on some things, but very high level. There's a lot to work with here. And I think, the big piece of work for the committee and the process is to identify what's the most important thing to do and what's the right order of things to do to focus our energy. We can't do everything, and we can't do everything for sure.
We
So-
can't do everything. However, we must do as much as we can. And I agree with you.
Fair enough.
And understanding that the healthcare delivery plan is something the board has asked for. EMR is something that has come to us from Oliver Wyman, and we feel compelled.
Yeah.
And the emergency piece is a payment reform. So if we stuck with the easy things, the low hanging fruit, we wouldn't go to payment reform.
Yeah, and
We
so
need to do that.
don't get me wrong, I'm not saying that.
Oh, good.
I'm saying, I agree with the sentiment that we have a crisis. And I guess I'll say again, just on a very high level, there's a lot of really interesting stuff here. I think there's stuff to work with to figure out how to stage it right. And I think I'll stop there.
Well, no, I agree with you. I hear what you're saying, and what we need to, what we need to do is to do the things that are gonna make a difference as quickly as possible. But then set the table for next steps. So a little bit of both.
Yeah.
Yeah. We can't be all things to all people. Oh, maybe. There's a lot here.
People can't study everything all at once.
No. And that, you're right. And so, but think about it, there might be some dates in here that send that piece out a ways and,
Prioritize.
Yeah,
What is our
prioritize.
goal for this year?
yeah.
What is our goal? And get this in some chronological order, because just sitting here and listening to it, it is so, I don't even want to start. And I can imagine hospitals that are trying to stay afloat, and you tell them, well, you got to do all this integrated planning and all that. That probably means they got to hire 3 people. I can see where they would be overwhelmed. So I think we need to just take time to say, this is our goal for this year. This is what we're going to do to get there.
So putting a timeline in place, it's important, I agree. And having the emergency events occur. Critical.
I mean, this is just our emergency. We have no idea what might happen in Washington. I mean, that could make this emergency look like the good old days. Think about it.
Yes. Thank you.
Come on, Sarah.
So, all right, well. Who else wants to tell us we can't do it all?
Water, that's perfect.
Well, look, we'll set a timeline. I agree with that. I do. I think that each of the pieces that are in here are important, and they've come to us from different places. Seeing, though the board sees, for example, the plan is really important. Maybe they'll come in and say they don't care about it anymore. We'll see. So we will take testimony. We will look at what other states are doing, and so we don't have to reinvent wheels all along the way. But I would like us to focus pretty much initially. We're going to have to focus on payment reform. We're scheduling people in to testify as they are available, but we're going to try and get a payment piece as much as we can. Some of some of those folks will not be available until next week, unfortunately, but that's the way life goes. And if
You might ask Representative Olson. What's happening in Rhode Island? We've had them in before because of their efforts in primary care.
yes, we have.
Did they succeed? Has it made a difference?
So Chris Kohler gave us a list of states we could look at. His strongest recommendation was Maryland, but of course, that's where he's had his experience. And we're gonna have people in from Massachusetts, who can
I
reach
look at
out.
Maine. I mean, it's got similar demographics. It's rural.
Yeah, Montana, yeah, Maine,
Montana is huge. But Maine is
okay.
relatively blue.
Yeah.
I mean, I wouldn't want to ask what Alabama does. Because they just don't do
I
it.
don't think they're doing any of
No.
this.
So, but somebody like
They're
Maine,
losing the market.
New England, got similar demographics, similar topography. That might be worth talking to.
Okay, we'll do that. All right. And I'll work with Nolan and Jen and Kiki, and we'll try and get some things set up. In the meantime, we're also looking at other bills in here. So I guess there are things in here that we should go forward with. My biggest concern is the emergency we face and cost, and trying to save, trying to save what we can save of the organizations in our state. Okay. All right, we're gonna take a little break. Unless there are others who wanna offer comments? Questions? I know you're gonna have comments, and I know you're gonna want to testify, and I know you're gonna make recommendations, and that's really important. Devin Green for the hospital.
One other question, can you give some more context to the GMCB collaborating with interested stakeholders to develop payment models? Like, we have a bunch of payment models
Yeah,
in here already.
that's I think, a next step.
Okay.
But it's really as I said before, is looking at where would you keep fee for service? Where would you put value-based payments, or would you put it everywhere, block payments? Because we know that some of those payment types disadvantage or offer risk more for payers versus providers. So that range, we'll have someone in who can speak to that a little bit, who's had experience in Massachusetts. So we'll hear from Jessica Morshella. She was in here the other day with UVM, and she does have information that's helpful.
One other state has done reference-based pricing. Montana.
Montana, I can't hear you, Senator.
No, I'm just wondering what, we could hear what's happened in Montana with, because if we do reference-based pricing, that solves the problem for a lot of other things.
Yeah,
You just.
you can use it in different ways too. That's the other thing. Medicare's, Diva's already done a lot of reference-based pricing.
Seems to be the new salvation.
Huh?
It seems to be the new salvation.
Well, it is. And if you're gonna do it for one group, then you save money for that one group, but it might change the billing for another group.
Yeah,
it's just
so
like-
I think what we heard Green Mountain Care Board said, do it across the board if you're gonna
Yes.
do it to prevent that.
Yes,
Question is, what will that do to the folks that are teetering on bankruptcy? And I
Yes.
assume reference-based would also go to would it go to federally qualified health centers, or are they federally set?
we can pay them.
There's a specific way in there. So specific ways they have to be paid.
Okay, so maybe we could
Mhm.
put
On our website.
yeah.
We'll have to ask. We'll find out. Yeah, a lot of this is, we have to find out. A lot of this is, we need the data and decision. Yes,
Sarah Teachout with Blue Cross, just to clarify, reference-based pricing is usually on the commercial side. Because Medicaid and Medicare set their own rates. So,
Then we
it's really.
set
the
yours
commercial
on
side.
a percentage, okay.
And it can help if you use it at hospitals for commercial payers, you can and try and regulate that way.
I think so
It does.
far it has been used in Montana and Oregon and their state employee. I think Montana state employee and Oregon is state employee and public and school employees.
Right.
Um,
That's where the request is coming from.
Okay, so we should see what that impact is. They're fairly rural, Montana's got lots of houses.
Doesn't solve the whole problem. Sorry. The board's comment about having it be more, having it broader is, I think, an important thing to remember. You're right. Your comment was well taken. Okay. Anybody else wanna? If you have suggestions for which state we hear from and who we hear from, I would very much value that. I think we all would.
Is that CSL? They might be a source.
I think Kohler, I think Millbank is a really
Yeah,
good
okay,
source.
yeah.
Yeah, we've got a good source.
There's gotta be a national group that,
Yeah. Yeah,
Wow.
and
yeah, National Academy for State Health Policy.
Okay.
yeah, NASHB is good, and they we did begin with that, and then went to Millbank because they all work cooperatively. So we're working on inviting the CEO of Millbank to come in.
So like California might have done it with their public employee retirements
Did they?
as well.
The retirement?
Yeah, well, for
Those folks be Medicare.
not all of them,
Okay,
it's better about hips and knees.
so we're gonna go on a break until 11:35 and come back. And we're going to be hearing from the Nurse Practitioners Association and Vermont 211. Yeah. And I welcome your help. I look around the room for help. Okay. But we need to do something. We cannot leave this alone. And the emergency is at the end is on page 3. The emergency piece are on the regulatory duties of the board and what they can do in the short term. They aren't going to turn on a dime. And we need to put as much in place as we can for now and for a longer term timeline. But as much of this as we can include, and we'll have fun.